Hello, I'm Dr. Michael Mayette, and today we're going to talk about the use of intraosseous catheter for reanimation situations. The intraosseous catheter can be used to achieve very rapid access to the central circulation. It is indicated both in cardiac arrest situations and urgent reanimation situations, for example, septic shock. There are very few contraindications to the use of the intraosseous catheter. First, if there is an inability to locate landmarks of the desired site, it's contraindicated to use the catheter. Also, the existence of a fracture in the targeted bone for the intraosseous catheter is a contraindication, as well as a previous orthopedic procedure with prosthetic material in the area. Finally, if there is an overlying infection at the site of insertion, it will also be contraindicated. Now, the approved sites for insertion of the intraosseous catheter are humeral heads bilaterally, proximal femur, and distal femur. We're going to go over in the procedure portion of this module. We're going to show the insertion in the proximal tibia because it is the most frequently used site. What you will need for the procedure is, first of all, chlorhexidine or alcohol swabs for disinfection, even though this is not a sterile procedure. You will also need the intraosseous needles that come in the size of 25 millimeters or 45 millimeters. The choice of needle will depend upon the patient and the site of insertion. For example, the 45 millimeters needle is always used for the humeral head insertion. For the lower extremity intraosseous insertion, both the 45 or the 25 can be used depending on the depth of soft tissue that you will have to go through to put the needle in. This can be estimated when you palpate the landmarks on the patient. You will also need the power-driven drill that will help you insert the intraosseous needle. You will need a 10 cc syringe of sterile saline for the flush of the catheter. You will need an empty Luer lock syringe to remove. You will need a dressing, and you will need some lidocaine if the patient is awake. For the procedure, we are going to first locate the landmarks in this proximal tibia insertion site. The landmarks that we look for is first the lower end of the patella, from which we're going to go 2 centimeters below where the tibial tuberosity lies. Then we're going to move 2 centimeters medial and find the flat spot on the tibial surface in which the catheter will be inserted. From there, we will do a quick disinfection of the site, measure up with our needle to make sure that we have a long enough needle for that particular patient, and then attach the power-driven drill to insert the needle. I stopped drilling the moment I felt a loss of resistance. Then I'm going to remove the drill and the stylet. Then I'm going to hook a connector that was previously primed with normal saline to the needle and flush it with 10 cc's of normal saline. Once this is done, you are ready to hook the connector to any line that you want to perfuse for this patient. It can be either fluids or blood products or medications. You would then apply a dressing on this site, and the intraosseous needle can be left in place for a maximum of 24 hours. After that, when we are at 24 hours or that the intraosseous catheter is no longer required, you would remove the connector and use an empty Luer lock syringe to use as a handle to rotate clockwise and pull outward to remove the intraosseous catheter. After removing the needle, a very simple dressing with gauzes and tape is all that's required. There is minimal bleeding associated with the procedure.